Hey, Jessica.
Hi, I'm just going to join from our office
Sure.
stuff right now.
Yep, no problem. I've made you a co-host so that you have the option to share screens and stuff like that. So once you're ready, I can admit people, but they'll be muted when they come in.
Okay,
So you don't have to worry about that.
if I can share the screen, let me close everything else that I don't need people to see about my life.
I know, right? Like all the fun of the back.
Yeah, I've been classy sometimes, let me tell you. Well, just I don't think people need to see my Spotify playlist. Okay, let me see if I can share what I need to here.
For sure.
You.
Okay, I see your presentation, Recovery Capital Index.
Yeah, so let's see. View slideshow. Why am I not? Oh, here we go. From beginning. Does that work? You can see that?
Yep, recovery management.
Okay, so that's fine. And then I'm just logging in through, should say boardroom or Jessica and Linda, I think maybe it'll say, as another participant so that I can
I see boardroom. Hold on. I admit that. And then
okay.
there.
Recording in progress. Oh, sorry.
You'll have to mute one of your.
If you want to. I'm not on. Okay. So if you could make boardroom, that's good. So keep us both on. Yep. And then I'm going to share from my laptop, this one that I'm on right now, and then Linda and I will be on.
Awesome.
So I'm just going to close this
off.
off.
Look like we're looking up.
Okay, so what I can do is I can zoom in a bit.
Mm-hmm.
Yeah, we are going to look like we're looking up. So I can shift over. Don't really want. Nope.
Right there's good.
That's good.
Yeah.
Okay. Okay.
And then I'm.
You don't need this, right?
Yeah, I do want that there just for the minutes part.
Okay.
That's the minutes part on that.
I'll keep track of the minute.
Oh, okay. Then I don't need it.
Okay. We're good. We got our booster juices. Okay. I think we're good to go now. Yep. We're ready.
Okay.
There we go.
All right. Got lots of people on there.
Yeah, lots of people joining us. Thank you so much for your patience, everyone. We were just making sure the camera angles all worked and we could see everything. And we will be starting with this session momentarily. It is being recorded. You are muted, but you have the ability to unmute yourself if there are questions. But just to keep the background noise at a minimum so we can get the most out of the presentation, we will have everyone muted.
Okay, well, I just want to say welcome to everyone. Before we start, it's where go, we can start?
Yeah, you can absolutely start.
So, yeah, what I want to start with first and foremost is I'm going to put a PowerPoint up on screen. Linda will be telling me next slide, blah, 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 blah. And then we've allotted about 5 to 10 minutes at the end of the session to answer questions so that we can do kind of a high level orientation to what recovery management is. And then we'll carry on through there. So I'm going to share our PowerPoint now. So let's see. Okay, so first and foremost, we both want to acknowledge that we live, we learn, we play, and we do our work on the traditional and unceded territories of the Cooksey First Nation, as well as all Coast Salish people here in New Westminster. This was the first capital of the colony of British Columbia. Cooksey means resting place, and the people of the Cooksey First Nation are often referred to as the river people. Our hearts are heavy with the confirmation of the burial sites of hundreds of children on the grounds of the former residential schools, especially knowing more confirmations will arise. There must be recognition of the injustices done, and there must be celebration of the history, heritage, and diversity of First Nations, Inuit, and Métis people. We are listening and we are learning. If you want to learn more about the unceded territory of the Cooksey First Nation, there is a Netflix series called Tribe of One, where Chief Larrabee talks about her heritage and the generational trauma that has happened on these lands. But I will leave that with you to continue to do the work necessary to educate, inform, and change our practices and organizations so that cultural safety is a reality.
Right. Well, good afternoon, everybody. It is later back east. I mean, I see there's a lot of people from everywhere here. My name is Linda Lane Devlin, and I am a clinician in private practice. I'm the founder of Interventions on Demand. I've been working in the field for almost 25 years, and I remember going to this conference in my early days and thinking that how ironic that, this many years later that we get to be seen as experts in this movement of recovery and addiction care. I've worked in government for 10 years in leadership, and then I went into working privately with families and with individuals with substance use disorder. And I'm really happy to be here today to share with you.
My name is Jessica Cooksey. I am the Director of Operations for Last Recovery Society, which provides bed-based services to men and male youth and transgendered folks. I'm also sit on a variety of different boards. I'm a strong advocate for recovery-oriented systems of care and recovery management, and being inclusive about the different pathways to and of recovery. Linda and I actually started going to school together way back, so it's definitely a privilege to be with you guys this afternoon, and I hope that you enjoy our session.
I might need to wear glasses to be part of it.
They can't see us. So
Okay.
Well, kind of, yeah.
So we express our humble gratitude to all the past and present clients, families, and colleagues who have generously shared their recovery experiences with us. A lot of the work is with us, and we want to say that resolving substance use issues is not just a matter of abstinence or symptom reduction, but improvements in functioning and psychological well-being and quality of life. So we're going to walk you through the session objectives. What we're going to cover here today will be describing the recovery paradigm. We're going to explore recovery capital domains. We're going to talk about and outline recovery management, and we're going to highlight the CACCF certifications for Recovery Capital Associate and Recovery Capital Professional. So we're really honored to be able to speak to that today.
So when we look at the recovery paradigm, it's really important to acknowledge the history of the recovery movement, the living experience of mental health and addiction recovery, to touch on what is recovery, the science, aka evidence or research of recovery, and then priorities, what recovery capital is, and then what strength-based approaches is to inform our discussion about recovery management. Oftentimes, especially I'd say in the last 10 years, that recovery has been a pretty politicized initiative, and we Dr. William White provides a very, I believe it's a 7-part series on YouTube about the history of the recovery movement. I really encourage you to dig into that when you have time, but really, organized recovery or organized community recovery, self-led, self-organized goes back to way before I was born, and it's really, the indigenous population self-organized for wellness and well-being long before the treatment industry and the professionalization of services occurred. If you have not read Slaying the Dragon, have a read of it. I don't know what's on your reading list, but I really found this really interesting. It really maps out the war on drugs, the stigmatization, the professionalization, the rapid growth of advocacy movements, recovery months, recovery days, recovery movements, the site when we started doing research on recovery, the life and recovery surveys through a variety of different countries. It also touches on the fact that harm in the name of health has been occurring within our populations for quite some time, especially for women and Indigenous people, but all populations as well. And I do want to acknowledge the impact that that has had on our recovery communities, and I understand why we started. I'm a person in long-term recovery. That's how I choose to identify myself. So I understand why we have a lot of community-based connections that have nothing to do with the professionalization of the counseling services or the bed-based services. So, in the 1970s to 2000s, we've seen a huge growth in mutual support groups. There's a variety of different 12-step model programs. We saw a growth in membership, which says that we're able to carry hope, that people in recovery can carry hope and carry messages that recovery is possible, that help is available, however you identify, and then that our diversity started growing, both in North America or Turtle Island, and then across the world as well. And when just a brief snapshot, of some more secular recovery-oriented support groups, and then religious-based or more religious-oriented recovery groups started cropping up. Age, duration of sobriety, ethnicity, orientation. It's just, we're able to specify the supports we need and self-organize in ways outside of professional services. So, as this, we were able to. I'm sure that those of you who have been in the field of addiction recovery or substance use disorders and mental health, that you have weathered or witnessed or experienced some of the growing pains and the conflicts and difficult conversations that that have arisen throughout our communities in the world. But the outcome of that has been
so where recovery came from, and where recovery has come from, is really recovering loudly, and we keep others from dying quietly. That is a true statement that when you think about it as professionals, we want to support who we work with to the best interest for themselves. And we're looking at different values and systems, traditions, status, beliefs, thought patterns, and this bodes well with any cognitive behavioral therapy that is being provided. And so the cultural consciousness is a point of where we need to understand what's going on out there, these movements that are happening for recovery and recovery journeys and recovery pathways is important for us to know when we're providing service, that we're not directing the path. Where recovery comes from, Jessica mentioned that it emerged from Indigenous practices. Then recovery emerged also from mental health services users rebelling against labels as ill or patronistic dependent mental health services. Then mental health went under the same umbrella as addictions and mental health, and advocates developed their own principles about mental health. Members of mutual support groups and self-help groups adopted recovery, and you hear it in some of the recovery-orientated programs. National recovery movement advocacy exists in many countries around the world. And the one thing that I want to really recognize is that even around the world, as recovery movements move on and they want to be able to identify themselves. So the recovery-informed paradigm is going to be about recovery-informed theory, recovery informed science and research. We always hear that research and science is how big decisions are getting made. You hear it every day on the news, and you hear it every day within our care systems. Recovery informed programming and practice. I think recovery informed is about understanding the path that the individual wants to take and how we can augment that. Recovery informed education and prevention. In terms of what we're going to talk about today is about really understanding the paradigm that is happening with successful long-term recovery, and that it's self-evident and fundamentally emancipatory, I can't say that word right, process, which means it includes us all. Leverages the self-evident phenomena of successful recovery, leverages and capitalizes common subjective landmarks of lived recovery experiences. I think it's really important to have people with lived experience on any of the work that we do. I'm also in long-term recovery myself, and I was a marginalized, street entrenched individual to begin with way back when. And today I identify myself as in recovery long-term. And it says we leverage the insights of successful recovery experience in order to bridge the knowledge gaps between recovery science and policy. The next slide is all about recovery, the recovery movement and Recovery Day. The United States does a really good job in understanding that there is a recovery month, a national recovery month in September of every year. I think in Canada, we're really trying to advocate for that as well on a policy level and government level. And so, there was a Recovery Day in a few of the provinces last year, and there was the year before, because of COVID, and there was an online one last year, and it was filled with like 40,000 people coming to, so they're recovering out loud. There's no notion that it's not happening. It's happening.
And as I guess the appetite for the science of recovery or researching strength-based initiatives or finding out about substance use disorders and mental health disorders, that there became a major debate around what recovery is and how to define it and who owns the term and who can call themselves recovery and what it should or shouldn't be. And so looking generally, and this is a generalization, I do want to emphasize that when it comes to recovery management, that how someone identifies their relationship with their substance use is theirs to determine and assign for themselves. That as professionals, we're here to walk alongside them, but we are not to label them. Granted, and I'll just park the being assigned disorders and whatnot to physicians is a whole nother, but when it comes to the term recovery, there's been kind of three leads on that. Looking at the kind of research and program evaluation is the Hazleton Betty Ford Institute, the ASAM, and then SAMHSA. And what they have, generally agreed on in their definitions is that there's four key components: that there's a pursuit of a remission of addiction, that there's improved global health indicators, level of functioning, and pro-social behaviors. In addition to that, the Recovery Science Research Collaboration came up with a definition that is an individualized, intentional, dynamic, and relational process of involving sustained efforts to improve wellness. So there's two definitions that are valuable to me from a program lens. When we look at this identity, this idea of identity or being in recovery or a recovering person or have recovered, when we look at the social identity theory, it may be an important motivator for change in treatment settings. If someone views themselves as a person in recovery, it may help them stay motivated to maintain this new identity. Exploring our clients' self-concepts and having them exposed and engaged with recovery supportive social networks could help shift their social identity from, say, a substance use specific identity to something that supports their ongoing long-term recovery. Addiction recovery is not an individual process. It relies heavily on the environment and social supports. Studies support the potential significance of social identity theory for addiction research. When we're looking into recovery identities, and this is just another lens to talk about the abstinent debate, whether someone needs to maintain complete, total, selective, whatever lens you want to utilize on that in order to be able to identify as being in recovery. From someone who's been in the field for over 2 decades, I really urge us all to listen with empathy and openness and hear what our individual clients and their families are asking of us and from us, rather than settling on what we think we already know about recovery or abstinence or anything else in this field. I'm always learning new things that I thought I already knew, or gaining new perspectives. So looking at recovery identities, do you want to speak?
Yeah, so we're going to show you a couple of studies that have been done. There was one qualitative study done in 2015, and the purpose of that study was to explore how social identities change during their addiction and during early recovery. There were 21 volunteers from a therapeutic community. Volunteers, predominantly male gendered, single, ages ranged from 26 to 58, had an average of 4 close friends. The interview was designed ensured that the study topic was unknown to the participants. The 3 open-ended questions that were asked: what was your life like before you came into the therapeutic community? And what has your experience been here? And what have you learned in the therapeutic community that you would help you when you leave? And so the study conclusions were that they were to identify the loss pathway, renew their pre-addiction identities after treatment, identifying and gaining pathway, building aspiration, new identities involving study, work, or family roles, and social factors are implicated in addiction and may act as either motivations for barriers. So out of the 21 participants, there was really and the identification that there was more work to do in terms of social capital in their lives, but it was definitely something that you can think about when you're meeting your client for the first time. I know I worked in the downtown east side, and we had a hub where people would come in, and the camaraderie of the connections that they had with each other on the street was phenomenal, because then when they did want a journey and a pathway to recovery, which was provided for them most of the time, and they were able to support each other in the journey and saying, yeah, I'm going to detox tomorrow. And there was this energy of positive reinforcement that they could do it. And even to the fact where when somebody would overdose on the street, we'd send out nurses and healthcare workers. But it was the people, their friends that they were using with, the drug users together, were supporting each other. Come on, you can do it. You can get through this, and trying to help them. And so that really in this study, it really kind of speaks to what are some of the factors that we need to be understanding in the identity and how they see themselves.
One of even in more kind of a male dominant study with a specific treatment modality, this study indicates, and it's a small sample, but it does indicate that there are still, 2 very clear pathways or identities, identity loss and identity gain, even with this small sample of, one, technically a pretty one-sided gender here. So when we look at creating a social identity or social identity creation in recovery, the recovery is an established term to describe the positive processes of change. That the creation is a strategy in which the individual acts strategically by choosing a particular narrative strategy at any given time. And that can be influenced by our intentions and our interpretations. So fear, motivations, however you want to look at it, and say the counseling process, that we may have different identities in different contexts. And we know this. I'm sure that, our workplace identity versus our family place identity are a little bit more formal and informal, that, we're looking at forward-looking and changeable identities, or stable and static, characterized by acceptance of who we are as a person. And I can tell you that being in long-term recovery and entering recovery, knew you could not pay me enough to go back to being a youth. I'm pretty satisfied being in my 40s, pretty confident in my identity these days. But there's also the disidentification process that can be challenging and characterized by tension and a consequence of interactional cultural obstacles. And what we're speaking to there is the fact that some people, the pathways or the resources that they use to initiate their recovery isn't necessarily what sustains their ongoing recovery, and that people access different resources at different periods of their life, in all areas of our life, i.e., ending accessing mutual support groups, or resuming access or initiating access long after their ongoing recovery. That some studies have shown that that while people may disidentify with being a person in addiction recovery, that they view their mental health as still a recovery process. So looking at a 5-year follow-up in Sweden from 2021, this one's more gendered towards women. That the purpose was to investigate people's experiences of self-identification of their recovery journeys over time. That it was that the interview questions focused on how the participants currently identified themselves in relation to their former substance use problems. There's 2 themes. That their substance use problem is still central part of their self-identification, that they are actively remaining or reinforcing identity related to alcohol and other drug problems. So self-identifying as an addict in a mutual support group is an example of that they're balancing different roles and identities, and that there's an internalized identity as being dependent. Theme 2 was that the substance use problem, or the issues that were being experienced as a result of the substance use issues, was no longer a central part of their identity. That what I just spoke to about the mental health issues, that they were questioning and replacing the recovery identity with something else, in that recovery, or being in recovery or from recovery, or however recovered, was no longer included in their identity. And that these results support the previous lived experience that's been expressed by people, that have shared on panels and whatnot, and in their personal recovery journeys, that for many, the recovery process involves an identity change, that there's a disidentification process, that experience of mental health issues was very common, that recovery processes research for different problems should pay attention to the subjective and temporal aspects, and that there's strength in conclusions on recovery as an individual identity process that varies over time. So when we're looking at the debate around abstinence, I'm encouraging you to perhaps look at it through another lens to help people unpack the discrimination and stigma that they have experienced as a result of some of our policies around that. So, and I won't go too political on that, but I do want to acknowledge the intersectionality of access and the types of services that people are provided, and the impact on their own wellness and recovery in their ongoing processes of quality of life indicators and social detriments. So I'll park that. That's a whole nother session, I'm sure. But when we look at recovery,
So, as professionals, we want to understand what recovery is going to mean for the individual that we work with. And, it's their path. And so as a professional, we really want to understand, what the person in recovery thinks it means, right? Like, what does it mean for you? Like, I'm working with an individual that he was drinking way too much, and when he drank, he was really embarrassing to the family, and he would get in lots of consequences and conflict because of it. And for him, recovery for him was about reducing his drinking and having a couple glasses of wine 2 times a week. And he would still do all of the recovery work that everyone, that we try to provide for people, the recovery management side of things, which we're going to talk about. But what we need to understand is how they self-actualize their own recovery journey, because they're going to ask you, what do you think about that? And I think it's really important that we ask them, finding their own purpose, achieving their goals and dreams, making their choices. What does self-help look like for them? Because some of them, might not want to go to 12-step programs, and they might want to go to SMART, or they might just want to have a friend group, to help them through that journey. So it's really important that we define wellness and recovery, that they are in that process and that we exclude it from anything else.
So I'm always curious about what the science and evidence looks like, because I work in a registered charity that provides bed-based services where our funding is contingent to the will of our healthcare system. So I'm always looking at what the evidence is to back up what I'm seeing frontline in practice base, or what people who are accessing these services from a variety of different backgrounds are indicating. And because I've worked in a facility that has been open for 37 years that is community-based, we have a large group of people that are living and enjoying life that follow up with us and stay connected over 3.5 decades. So I am seeing the outcomes of people's quality of life indicators and access to a variety of different supports. So one of the things that really spoke to us was the Sheedy and Witter, and endorsed by Dr. David Best in 2010. So over the work of engaging 20 years of research reviewed, and then consultations with people with lived experience and working in the addictions field, is that there's some principles of recovery that have been developed. And this is a set of principles. A variety of different countries have made commitments based on principles of recovery that are reflective of their own demographics and their own consultation processes. But I like these ones, so we're sharing them in this session. One, there's many pathways to recovery, that it's self-directed and empowering, that it involves, a choice, personal recognition for the need of change and transformation, that it's holistic, that it has cultural dimensions, that it exists on a continuum of improved wellness and health, and that it's not just a treatment event, that it's a continuum.
Mm-hmm.
Go ahead, Linda.
Yeah, and also it emerges from hope and gratitude. I love the saying that we're hope carriers, that we get to carry hope and help people see the things that they do have in their life. Recovery involves a process of healing and self-redefinition. Like, I know I don't see myself as the person I was, I see the person who I am. Recovery involves addressing discrimination and transcending shame and stigma. That's really important for the empowerment, the power of how an individual sees himself. I have no problem calling myself an addict. I have no problem knowing that, I have to remind myself that, it's very true and real for my life experience, but today I'm a recovering person. And recovery is supported by peers and allies. Recovery involves joining or rejoining or rebuilding a life in the community, and recovery is a reality.
So part of what happened in British Columbia a couple of years ago is that there was a statement made that recovery is not only possible, it's probable with the adequate resources. And that really spoke to me. When we look at the recovery paradigm, and there's way more research than what I've cited on the slide, but I did want to touch on a couple research-based kind of evidence, so to speak, around this. There's definitely more. If you want more, I have lots stashed away on my Dropbox. But that there's a shift from a medical model, that we don't need to be fixed or treated or solved, to a recovery-oriented model, that addiction doesn't just happen inside the body, that one specific treatment modality isn't going to solve, isn't going to only, it's not just a healthcare supported. We need resources throughout all different social detriments in order to sustain our ongoing recovery, that the social and community are essential and intrinsic part of the recovery process. This speaks to, also the broken window theory. It speaks to access to, meaningful and healthy meals, housing, employment, education. It speaks to really about the community in which people are being exposed to when it comes to recovery, and that it's interdependent with the community in which it occurs. So we can go off and get acute-based services, but if you put us back in the same environment that we were when we started, it's unlikely, or it's less likely, that we're going to be successful in our identified goals. And it's also challenging the historical story of that, once an addict, always an addict, that treatment fails, that nothing works, everything's ineffective. The founder of Last Door says everything works for someone, and we need to never minimize the fact that everything works for someone, that all hands on deck are required in order to provide hope and help people. And, when we're looking at the research, there's researchers, there's advocates, there's activists, that it arises out of the intersectionality of personal, family, culture, and society context, that this isn't just a moral failing of people who choose to use substances, and that we are here to work as partners, not paternalistic treatment providers, that it unfolds in a variety of different patterns and trajectories that admit, treat, and discharge stabilization that are wrapped within extended continuum supports. Our evidence shows that it's more effective, go figure, that, assertive outreach or pre-recovery engagement, recovery initiation, maintenance, and enhanced quality of life for long-term recovery is really important to start researching and emphasizing, to change that historical story that there's no hope, and that, research has indicated that over half will eventually achieve stable recovery. That's long-term recovery. That exposure to role models and a sense of person and purpose and meaning predicts recovery. That key predictors of recovery are active community engagement and immersion in peer support groups. So Dr. Best at the Recovery Catholic Conference indicated that people in recovery are more likely than the general public to volunteer and practice citizenship in their communities. Mm-hmm. That's kind of interesting. I mean, I see that in practice as well. So it spoke to what I've already been observing, which is inspiring. That recovery requires a twin track, that there's enabling, supporting individual recovery journeys, and there's also creating those environmental conditions that enable social contagion recovery, and that recovery is transmitted, so to speak, through social networks and dedicated recovery groups. So I know that a lot has been researched on resiliency. Absolutely, resiliency is very important when it comes to people's capacity or competency to develop life skills or be able to continue on the recovery journey. But it's not on the person to just pull up your pants and get in the game and just lean in when things are hard. That messaging can cause harm to people who have experienced complex traumas, that have a history of being discriminated against or excluded from accessing key services that give them the basic needs that they need to be met. So part of it is absolutely take resiliency into consideration, but it's not the end all be all. So go ahead, Linda.
So, and in terms of quality of life, the World Health Organization defines quality of life as an individual's perception of their position in life in the context of the culture and value systems in which they live, and in relation to their goals, expectations, standards, and concern. So it's a broad range concept affected in a complex way by the person's physical health, psychological health, personal beliefs, social relationships, community connection, and or lack of, right? And so quality of life is about, most people, when you talk to somebody who's just coming into their own recovery path, are missing a lot, and they feel they've lost a lot. And even the people that have lost everything, and I know that because I did. And, when you're in that position, anything, the most important part is that you do want a quality of life. You want to believe that it's available to you. You want to believe that it's possible for you. And I love the atmospheres that promote that, that you can be who you want to be rather than figure out always who you are, right? Because who I was is not who I am.
So when we look at recovery capital,
Right.
it's kind of it's a means to measure some of these quality life indicators.
Mhm. And so recovery capital, it refers to the sum of resources necessary to initiate and sustain recovery from substance use and boosting one's capacity and opportunities for recovery. A lack of such assets hampers the recovery process and desired outcomes. We need to identify strengths, support building and maintaining a sustainable livelihood, looking holistically at all domains of life and meeting them where they are at. So even though someone is not at a place of having the best quality of life, we want to be able to use recovery capital lens on helping them understand that that is possible. And those are the areas, it's like wellness wheels. You know, I'm sure a lot of you use them in your practice. There's a really good way to break down, and the recovery capital piece is that sum of all of those resources that can help a person to success. And success is an individual thing as well.
So when we look at the components or the domains of recovery capital, there's actually a couple additional ones that have just been defined, and that's justice capital and an institutional justice capital as a result of some of the research that Dr. Best and his colleagues are doing on people who are exiting correction facilities or involved in the justice system, depending on which country that you're in. The label's a little bit different, but in general, there's social capital, which is, you know, your relationships, or as a result of your relationships and your obligations to those social networks, your tangible assets such as property, money, skills, your human capital, which is the skills, positive health, aspirations, hopes, dreams, goals, and cultural capital, which is the value, beliefs, and attitudes that link you to a specific culture. Building social capital is a visible central element of sustained recovery management. And so Dr. Ledet and Dr. White, there's been quite a lot of research based on measuring recovery capital as an indicator for ongoing recovery, what initiates recovery. There's been research in a variety of different age groups, demographics, gender, all, you know, specific treatment modalities, community-based recovery measurement. So it's really quite an interesting area to read into the research and the measurement. I'm biased, obviously, because I've worked with people who are engaging in their own recovery pathways. So I'm always curious to see what's happening in other areas of the world. Are what we are experiencing in New Westminster and British Columbia or in Canada similar or different than other areas? What's working, what isn't, and it helps inform, you know, some I guess a community needs assessment that we may need, and I'm curious to find out how other people are adapting. What we do know is that increases in recovery capital can spark turning points that end addiction careers, trigger recovery initiation, elevate coping abilities, and enhance quality of life and long-term recovery. For those of you that have also worked in bed-based services, I don't know if you've had similar experiences, but I have had some people who have done the tour of public and direct pay treatment services that on paper look like they are going to need long-term treatment. But what Recovery Capital has shown us is that when people still have a set of skills and competencies that can help reinitiate their recovery, that sometimes just getting their feet under them, having some housing, re-engaging with a community that's supportive of their identified recovery pathway is what they need. That historical lens of you have to do withdrawal management, and then you have to do bed-based services, and then you have to do continuing care. Sometimes that's effective, and the studies definitely indicate that it is, but other times, sometimes people need to be reconnected with a recovery community, and they carry on. They go sleep on someone's couch, they get connected with people in recovery, they get a job, they carry on. But on paper, they look like a hot mess. But in practice, because they still have recovery, they still have those social resources, they're able to initiate their recovery. Again, I'm sorry, my phone is ringing.
That's okay.
So when we look at validated tools, you know, and that harm in name of help, what has evolved as a result of the research is a validated tool called the Brief Assessment of Recovery Capital. And in the handouts, we've included the article that talks about the validation of this instrument. We've also included the 50-point recovery capital assessment for your reference. And these are some pretty direct and basic questions, but again, it really does, from our experience, is that it really does cover off a lot of the key areas that we discuss about initiating an ongoing recovery. So the average score at 12 months or a year in recovery is around, uninterrupted recovery is about 47. What we're finding in practice through the My Recovery Plan is that it ebbs and flows just like the rest of our ongoing wellness. The other part that I've been really curious about to learn more about is under what circumstances is recovery possible? Because it's a question that a lot of families and individuals ask at the onset or the initiation of seeking supports. And we touched on this briefly, is that the social identity, learning, and social control, there's supports and social learning, merged to create hope, that there's scaffolding that enable people to develop tools, commitments, and motivation to support the recovery process. And then there's the recovering within the communities, which is asset-based community development. Mm-hmm. These are three of the books that I really have enjoyed. So if you are looking to add them to your reading list, by all means do so. It provides a good lens for me to kind of overlap the different theories of wellness and healing. And again, I'm sure any of you that have ever done a genogram, trying to map that out in one session, it's speaking with people around their relationships with substance use, their shame, guilt, hopes, dreams, and goals, what they really want, identified goals, supporting recovery. It definitely requires a complexity thinking that recovery or healing is not very often, have I seen, if ever, a linear process where, a little, algorithm through the system. It's not, part of it is that it does self-organize into a coherent system, but it requires monitoring and feedback and connections and periods of uncertainty and adapting to life showing up and evolving and emerging. So when we talk about people's wellness journeys, it's very difficult to write a cute little paragraph about them, but this is generally what sessions can look like. And just to really emphasize that we do not recover alone in our physical bodies, that the capabilities, assets, both material and social resources, are required for a means of living, that housing alone or employment alone or treatment bed alone or social supports alone likely can improve people's life, but sustaining it may need it all, So when we're maintaining or enhancing our capacities or assets and, providing benefits to others' livelihoods and locally and more, that we're all connected in a system. And it's not one resource or one, part of the system that should be responsible for covering it. So I think that's, I like this kind of look of sustainable livelihoods and recovery capital. It really takes a look at the impacts of different policies, different access points, what it can have on people's enhanced recovery or building their strengths and supports necessary for their ongoing recovery.
Yeah. And just to add to that, I just want to say how with the social capital side of things, like family involvement has been proven to be very powerful in better outcomes for people that are including the family, and some can't. Some don't have that in their story and in their journey, but the ones that can have it in their journey and want it in their journey, it's a powerful capital to have. And so in terms of the development, and if you want to treat and an illness that has no easy cure. God, I'm not reading properly without my glasses. If you want to treat an illness that has no easy cure, first of all, treat them with hope. And we talked about that earlier, being hope carriers. And now we're going to talk about recovery management. And recovery management, we're wanting to look at the sustained stewardship of personal, family, and community resources to achieve the highest level of global health and functioning of individuals and families impacted. So again, back to the families, you're going to want to, provide whatever way you can, like part of the services in case management works really well with families. And, the ARISE model of intervention is a really good one where they're including the family in the process of healing. And so the focus doesn't just go on the person that's using substances. It's actually, how do we heal as a family? And it's a collaborative model between service consumers and traditional and non-traditional service providers aimed at stabilizing and then actively managing and the ebb and flow of chronic behavioral health disorders. So we're going to talk a bit about the framework with recovery management. And so it's a strength-based, client-centered focus. The model empowers the individual to move towards a healthy, productive, and meaningful life. It's recovery outcome driven. So recovery is intended as a continuous process with access to really good practice and evidence-based services. And the client can be assisted through the stages of rehabilitation and social integration, so reintegration. And so there are many pathways to long-lasting change, stability, regaining a sense of identity and self-esteem. They have a lot of peer programs in Vancouver's downtown east side, and there they learn some of the job skills of, even while they're still actively using substances. But what happens is they start to feel like they want to be a part of society and they want to make more changes. And so influencing, recovery management in a lot of those cases is to build and empower the strengths that they have. And we used to call them transferable skills. I think you all can remember that. And so we also realize that the context influences the recovery process and the likelihood of recovery outcomes. I can guarantee that every single person on this session is committed to wanting what's best for the client. And so the recovery framework starts by promoting cultural relevance and gender sensitivity. So that's really important to facilitate gender mainstreaming by considering and planning projects. The barriers that make access to treatment difficult for women. There might be stigma, scheduling. Some people can't go to residential home-based services, so they're going to look at outpatient opportunities, recovery coaching, things like that. Daycare, that's another one that is really hard for moms to get and do the work that there's some really good community programs like Mothers in Recovery and things like that are really trying to reach them at the end of the day after they've been being moms all day and need that time for themselves. Aims at promoting assertive approaches to integrated and continuing care. These approaches are emphasis on long-term supportive relationships. And so continuing of service to increase their recovery capital. So if we're using recovery capital tools like recovery management tools, we're going to understand, weekly possibly, like how we're having these checkups with them and monitoring how they're doing and what is an improvement, like what could they do differently and what could they do to work towards feeling like they are moving to a quality of life that's good for them. Next slide. It also integrates clients' respective families. And like I said, some families can't be involved for many reasons, or partners in recovery. There's relationships that have been tainted by substance use. So we want to see how they see that. How do they want to repair that, or do they? And so the community, you can see the community as a reservoir of resources, opportunities, and support, where you're recognizing that no organization, no single organization, institution can provide everything that a person needs. It is like a collaborative approach. And, and we know our lane, we know what we work within, and we know what we don't do. So there's a lot of sober living environments that are starting now too, that really help understand recovery capital and how we can help people to success. And then recognizing that combating and overcoming stigma of drug dependence is essential to gain and maintain the community's support. I know there was a speaker earlier this morning talking about medication management and alternative therapies. We as, again, respecting the path that people need to take, right now, people are being prescribed medications where they are able to come out loud about that and really recover, and for their own decision whether they're in recovery or not, that's for them to decide. And I like that even the 12-step programs are adjusting and learning. I was at a world conference in Florida a couple of years ago, and they were having stakeholder meetings with NA members to try to improve the way we were welcoming newcomers and people that were coming new to the program on medically assisted therapies and how we could help them recover. And so, I think,
So, when we look at the components of sustained recovery management, and what Linda highlighted is part of my role in my life is to advocate for people's access to the supports that enable and sustain people's ongoing recovery. And part of that is really emphasizing that the one size fit all doesn't necessarily apply or work for everyone in specific contexts, challenging the tendency to, like the two studies that Linda and I highlighted, they're not a cookie cutter that can be plugged into other contexts or other communities and taken as best practice. And sometimes that happens at a policy level with really grave consequences for people needing support. So part of looking at the components for sustained recovery management is looking at that not only personal inventory of people trying to persevere and practice resiliency, but also looking at our systems and services and finding working for a charity, there's always a scarcity complex. There's always, we're competing for the same grants. We're trying to have funding for our additional programming that some of our public that we just wouldn't be able to without donations. However, that should not come ahead of collaborating with other service providers in our community in order to ensure that there's transitions between our services. That ethically we have a duty to ensure that we are playing an active and assertive role in enabling these components of sustained recovery management. One of them is physical and mental health. We know that poor dental hygiene can lead to some serious chronic health issues, which I might add are expensive to the health, to the acute healthcare system. So covering off someone's early dental work while they're on income assistance or welfare-based public bed would be more financially feasible and smart than not doing anything and declining that request from someone. We know that mental health symptoms or triggers can escalate after people choose to stop using substances, that it takes a while for stabilization, that oftentimes were considered complex cases. We know that family social supports and leisure activities are pivotal for people to start experiencing joy or happiness or connection. We know from practice-based experience that families are often exhausted. There's a family systems theory about that tension or that friction or sandpaper that happens when someone in the family system decides to act differently or practice different principles. It creates some disconnection and some consequences or conflicts or power struggles, however you want to look at it. And part of looking at sustained management is acknowledging that can happen. Safe housing that's conducive to recovery and environments that's conducive to people's ongoing recovery is essential to support people that and don't get me wrong, there are definitely people who are using or who are in long-term abstinence-based recovery that reside with people who are actively using substances. However, when someone is looking to initiate their recovery process, the ability to have access to supports that they self-identify as meaningful is really, really important. When we look at peer-based recovery supports, there's a process of grief and loss that happens when someone exits their addiction career and transitions into a more recovery-oriented environment. They're grieving the loss of intimate friendships that we need to hold space and honor that. That's my personal experience and opinion. That's not, could probably find out, but again, there's a process of grief whenever change happens in our lives, and sometimes, earlier on in my career, I demonstrated impatience or intolerance for that process. What I know now is that honoring someone's thoughts, feelings about a change in life is pivotal to them feeling connected and being able to unpack that and identify goals that are meaningful to them. That employment and resolution of legal issues, sometimes building recovery capital is something as simple as applying for identification after not having some for a decade. Sometimes it's helping someone practice interview skills before a job application. People have actively disengaged from services at the mere thought of having to apply for a job because they feel that they are unworthy of such. And that is a result of a myriad of different things: family of origin stuff, core belief systems, discrimination and stigma at a systems level, a lack of availability of employment services. There's a lot of different things that impact that. But part of looking at sustained recovery management of if someone's current employment does not support their ongoing recovery, then supporting them in unpacking about how they are going to transition out of that role and why is a pivotal part of recovery management. Looking at legal issues. Some people think it's a great idea to shack up and play house, and then they are married for a long time, or they may need to exit out of a relationship in which divorce or restraining orders or anything else that may happen, or they may have speeding tickets, or they may have more serious legal issues. Part of looking at that is step by step unpacking how to make meaningful actions in a way that supports where the person's at, rather than just being like, oh, well, just go turn yourself in. Mm-hmm. We talk about a recovery management plan before that happens, and then looking if people want to engage in the education system or develop a career or a trade or exit out of a trade. So part of looking at all of those areas, those things aren't just a one-time substance use assessment. These things are ongoing with checkups and counseling and support from peers and other resources in order to keep on keeping on. So when we look at community integration and cultural renewal, there's been when we look at the community integration part, again, like Dr. Best indicated, that people in recovery are more likely to volunteer than the general public. I'm really curious to know why that is. Is it because they want to feel connected to the community? They want to reintegrate into, mainstream society, so to speak? Do they want to identify as being in a subculture or a specific community that isn't mainstream? That process facilitates practicing self-regulation. It may release emotional trauma that people were unaware of that they were holding. It can also alleviate isolation. It can also encourage, having new experiences, new consequences, new risks, and then also create a sense of interconnectedness. But building a support network of people in recovery, our individual clients, patients, residents, however you want to identify them, the recoveries have different experiences and are carrying different historical traumas that may surface as a result of engaging in the distant components, and then looking at that meaning and purpose in life. Sometimes in the second and third year after completing treatment, some of our guys have come back and said, I know I should be happy in the life that I'm living, but I feel nothing. I feel disconnected. I feel like ending my life. And part of that, like I said, sometimes it's mental health, sometimes it's just there's some areas that they're ready to take a look at that maybe they weren't in their early recovery. But again, just looking at that meaning of purpose in life, that's something that has been identified as essential to people's ongoing connection with themselves and others. And that involves a reconstruction of that identity that we spoke about, really living a value-based life, and then having people, interpersonal relationships that we enjoy. And then that, collectively facilitates reintegration. But when we look at that, there's competence, there's humility, there's cultural this, there's cultural that. But at the end of the day, it's great to have that self-awareness as a practitioner. But unless our organizations or our offices or our services are demonstrating cultural safety, we will continue actions that either intentionally or unintentionally continue to exclude or marginalize or harm people who have historically been marginalized and harmed as a result of our systems. In Canada, there's decolonization, which is a really important term to understand and apply in our organizations, and that we don't get to choose what safety looks like for someone. It is the people in which that are accessing our services. Each of those people define whether they feel safe. It's not a little checkbox that we can put in our policies. It's an action-based initiative that we need to continue to sustain and implement and check ourselves on in order to ensure that people that that don't have the same amount of privilege I myself have been awarded in life. Even Linda, who has been, has experienced some pretty serious, like we on paper have been privileged more than other people. And part of that is checking our privilege, being aware of it, and knowing how it interacts with the services that we engage in, the policies and organizations we choose to be a part of, and raising awareness about how to promote cultural safety. So if some of you on this have not taken cultural safety education or training, I plead with you to please continue or consider to do so. It's a very pivotal point that impacts our communities. Part of looking at that is looking at promising practices, is that many of our professional-based services are based on evidence-based or best practices or what have you. But when we're measuring people or populations, we're measuring generally mainstream populations, and that those marginalized populations or overrepresented populations don't necessarily have a voice. So when we're looking at promising practices, we can demonstrate them by using objective measures in one or more organizations. They show promise in replication or context-specific adaptation, that they're long-term sustainable, and that they have the possibility of becoming evidence-based practices. So like I said, we've come from cultural humility, cultural competence, and now we're looking at ways to become having cultural safety in our practices. So that has evolved out of the efforts and actions that have been done to date. So where are we at with time?
Oh, we're doing pretty good.
Okay.
Yes. And so now we're going to talk a little bit about a few different recovery management tools that are out there, and we'll get to that in a minute. But I really wanted you to talk about, Jessica, the CACCF, who are the hosts of this conference, which thank you very much. And I want to give a shout out to all the certifications that I continue to stay current on. And thank you to Crystal and all the work that's been done over the years through the CACCF. And I think credentials are so important. Even when, we have degrees or everything, I think the certifications and ongoing education is really important for us as professionals, because I'm always taking courses. I'm taking courses on family case management, family systems theory. Like, it is important to continue to grow as a professional, because we do need to be culturally responsible, and we do need to be ethical and be guided in the right way. So Jess is going to talk to you about 2 different certifications through the CACCF.
Sure. So a little bit about the CACCF, if you're unfamiliar with it, is that the mandate is to protect the public. And how that's done, or the efforts that are made to be done, is that we promote, certify, and monitor the competence of addiction-specific counselors in Canada using effective practices which are internationally recognized. So there's thousands of people certified throughout, looking at the different voluntary organizations on Turtle Island alone. You can see that the workforce is committed to voluntary being accountable to the public, ensuring that there's ways and means to address any ethical violations. So that's really important for myself and others. So part of what a shift is that anyone in most of our provinces in Canada, anyone could call themselves an addiction counselor. Anyone can call themselves an interventionist or a therapist. There's no law against it, so to speak. So when we're looking at supporting the public in knowing the competency of a counselor or the bed-based service that they may want to direct pay into or whatnot, we're looking at having staff certified. And at Last Door, we provide supports, financial support, so that our support workers can continue on in their education, and it's a requirement for them to become certified, so that not only do they have complaint processes in our organization for clients, but they also have someone outside of our organization that they could file a formal grievance with should any of our staff act unethically, and that reinforces public safety. So part of that is the evolution of certifications or endorsements. One of them is the Recovery Capital Associate. There's 6 steps for someone to become an RCA. Obviously, membership in good standing, complete hours for building recovery capital, read and sign the consent form, kind of ethics, and then apply. And then there's also the Recovery Capital Professional, which is coming. A similar process, but pretty straightforward. But the expectation is that people would continue on in their education and training, and this would supplement their counseling practice, so that we are focusing on recovery management and supporting people on their journeys. So if you're interested in that, talk to the office about that. And then the other one is a Canadian Certified Recovery Coach. And there's 8 steps to completing this one. I'm really excited about this one because if you have not, or you're considering what sessions to attend tomorrow, I'll get to that. But it's very specific on what it takes to be a recovery coach. It's different than being a counselor or a recovery capital associate. There's some key domains and key competencies and capacities that are required for that. So I do want to flag this session tomorrow. Dr. Ray Baker will be presenting. If you have not attended his session, please do so. I think he's phenomenal. He's really informative. He knows his stuff. He has decades of experience working with people with substance use disorders and mental health disorders and people on long-term recovery. So he's a certified recovery coach as well. So I definitely trust his experience-based knowledge and also his professional knowledge. So if you haven't chosen your sessions for that, I'm encouraging you to check that one out. I'm a little biased because I just think it's
he's
pretty amazing.
It is amazing. My husband actually took the training with Dr. Baker, and he just loved it. And the other one I want to give a shout out to the CACCF is that they're moving forward into intervention specialists as well. I had to go to America to get my.
Remember when it was called the Addiction Intervention Association?
It was way back.
So part of having certifications and being accountable to certifying associations is that we speak with our unified voices to ensure public safety. So
Yeah.
there's been definitely, I don't think that the history of the harm in the name of help is concluded yet in North America, and I'm glad that they are continuing to offer certifications to help the public feel safe. So part of recovery management and looking at what kind of tools are available. There's some electronic app-based ones and then some hard copy ones if you want to.
So I'm just going to talk a little bit about what the recovery management tools that are out there. You can explore them all. We're going to kind of go through a few of them here. And it's the ability to track and help stimulate the components of recovery capital with individuals. And so it's also self run as well. So you're going to help as a professional, help them see what kind of tools are out there and see how they can use those software resources. They include a variety of validated instruments, encourage you to explore them once you have time, and they are all HIPAA and FIPA compliant. Wagon, Hazelden, Green Space, and Recovery Capital Index, and My Recovery Plan. So Jess is going to talk about
the Wagon. Okay, so this is like kind of an online outpatient clinic for mental health and addiction. It can be used for people who that can't travel to bed-based intensive treatment or bed-based recovery houses. That it's a mobile app for clients, that there's a dashboard for clinicians, and that you can schedule, host online sessions. It's secure video conferencing. It's available in remote locations. Relatively, I know that there's rural areas that, we're still, many of the people in this field are looking at ways to engage with them. And it helps balance out those responsibilities. And the evolution of these apps speaks to the fact that the historical story of what addiction looks like or what substance use issues looks like for people is evolving. That you don't have that it's not just those homeless folks. It's all of us. That it does not discriminate. Some of us are more likely to have mental health and substance use issues as a result of some family stuff. But, overall, the fact that these are successful and effective speaks that we are reaching people that we weren't able to reach before. So the goal is to maintain that therapeutic alliance, which I think is definitely primary in any counseling relationship, that it can reach people in remote areas, that it provides care-based real-time data, that there's specialty programs that can't be filled in person. So this is kind of a compromise, and that there's long-time data that can inform our programming. So there's the app, the dashboard, and video conferencing. This is kind of what a screenshot looks like. And then there's the privacy that's covered off as well, which is really important, that we're able to be responsive and responsible for our connections with people. And then
Hazelden. So one of the things I wanted to say too about the tools that we're presenting to you today is that and there was a question last night on the audience for this session about marginalized populations and how they could access recovery capital and how that can work for them. These apps and these tools are, one of the things I've learned over services in the downtown east side and, hubs in your city that are frontline workers, like they have computers at every single one of them. They have to go to workplace employment hubs as well, and there's computers there. So I think as a professional, if you're working in frontline, that you want to find out what these tools are so that you can help support individuals that want to get started on their recovery capital assessments and to be able to do some recovery management right from where they are, where they're at, and see how, that hope is possible, and so is recovery. So the Hazelden Betty Ford has many tools. I mean, if you look at them, there's the field guides, there's one called Life, one called Core 12 app. These services are all part of connections for intensive combination of recovery support and monitoring. And it has been through treatment. They're for people that have been through treatment multiple times or facing a loss of a professional license, are struggling with legal issues or custody matters, they're planning to return to college or need additional accountability. So these apps, go on the Hazelton website, you'll be able to see them.
So GreenSpace is another dashboard specific software that counselors can use because, research has shown that consistent use of objective measures in therapy improves overall treatment outcomes. I'm sure that we all know that from our own experience. So, it includes validated instruments, not necessarily the Recovery Capital or the BARC 10, but there's some assessment tools that are available, and then you can input your case management system in there, and then it tracks progress over time, including the therapeutic alliance.
Yeah.
And then there's a couple Recovery Capital specific ones that I thought we could just highlight quickly.
Yeah, the RCI is an automated survey that measures a person's well-being and personalizes their care plan.
And
so it looks at 3 areas: social, personal, and cultural capital, and you track and build your recovery capital as you go, looking at all the supports that you need and what are some of the things that you need to address. And we talked about this through the presentation around cultural capital, personal capital, and social capital.
So as you can see, it covers off all those key areas or key components of recovery management.
Yeah, so they do them in real time and they manage an entire population across providers. Like you can link into it, whether you're working in the clinic to the treatment programs to recovery, sober living. Like there's ways for people to access it online. The RCI is delivered automatically as a digital survey to patients, and they can also do a lot of analysis and reporting. Develop your own with a powerful feature in it for self-analytics. So that's the RCI. And then now the My Recovery Plan.
Yeah, so part of how I came across these different options was we were looking at digitizing some of our processes and transitioning to more online kind of SharePoint kind of cloud stuff with our guys so that we could continue, so that we can get real-time data to inform our programming at Last Door. And what we settled on was the My Recovery Plan. If you want to know why, we can have that conversation offline, but I'll just give you a quick overview of it, is that it's an electronic health record like the other ones that we showed you, that it tracks the recovery person's pathway while they're in our services, and then as they exit out of it, there's an app that they can maintain their goals and stuff, that it's not directly dependent on Last Door specific, that it measures unmet needs, barriers to recovery, and then the recovery capital domains, and you come up with either a negative, if you have nothing, it's negative 100, and if you have everything, it's 100. Positive 100. So, for us, residents come in with their score are fairly low at 17-ish, 24-ish. Those of them with really that are scoring, they're claiming 8s and 9s on some of the questions. It's usually a flag that that they may be experiencing some. Either we're not necessary for their ongoing recovery, or there's some serious things that are happening that they're just not ready to look at, and that we note it. So so it does the tree thing where if we are building the kind of roots of quality of life, commitment, community capital, social capital, personal, then the tree is going to flourish. If those resources are not available to support people's ongoing recovery, then we're going to see a bunch of reds and yellows and no greens. So it covers off all of these domains. Some of these don't really matter in the beginning of recovery or in long-term recovery. These and the score ebbs and flows throughout recovery. But the goal is to identify barriers and resources to help them overcome them, plan using, real conversations and meaningful engagement so that we can come up with a recovery care plan rather than a treatment plan, and then set up specific goals. And like I say, it can be something as specific as getting the application look at how to apply for ID. It's not about just getting the driver's license, and that it captures the work that people have done throughout their processes. So when they have those, when they question if they're on the right track or if this is working, they're able to not only look through their journals or whatever self-reflection tools that they're using, they're able to track the efforts that they've made to date. They're able to see that their ups and downs, they ebb and flow throughout the recovery process, that staying in that linear path is probably unrealistic. And so it's 121 assessment questions, so it's fairly long, that there's automatic goal templates triggered by responses, or you can make your own. And then here's like 3 basic maps that we utilize. I don't know if they're applicable to your organization or your services, but we look at what was your success. So we're capturing on the strength. We're looking at if there's any kind of barriers, and then, a decision-making process as well. So we're able to capture that. Some of our residents would prefer to have these conversations as conversations rather than writing out a form. They shut down when they see this. Others really like mapping it out. It really depends on the individual. So this isn't a cookie cutter, just get them to fill out these forms and that's that. We have a bunch of different tools we use. But again, this is recovery specific management. So the other thing that we have included in the handouts that are uploaded to Whova is a bunch of worksheets that are off of the William White papers, and another that we've cited on the actual handout or the worksheet just for reference. There's some recovery capital plans and scales. There's a trauma informed practice reading list. It's quite lengthy, but I hope that you
It's amazing. Yes.
Hopefully you can pull some resources off of that. And then there's the validation article about the BARC, and then an assertive continuing care checklist, and then a weekly recovery activities. So, I prefer to provide some resources and some kind of stuff for you to have a look at and see if it can inform your practice or not. If you have resources that you think would be meaningful or valuable to Linda or myself, by all means, send them our way. I'd be happy to have more resources as well. So that about wraps up the elevator speech of recovery management. I know it's quite a lot in one session, but I just, we wanted to touch on a couple, the kind of key areas. There's a lot more to unpack. We could have a whole week-long recovery management intensive, but
We've done that. We've done that.
Yeah, so it's just, we try to touch on some key points throughout this, but it's not exhaustive by any means.
So what we've been able to do today is describe the recovery paradigm. So we're shifting from the relapse prevention to the recovery capital, looking at the strengths that people have and the hope going forward. We've highlighted the transition from acute interventions to recovery management. We've identified personally and professionally directed recovery management and have given you some examples of some tools that are out there and some certifications that will help you along the way. And then the Recovery Capital Conference as well coming up soon, right?
Summit, yeah.
And
then there's a CSAM. There's quite a number of conferences. I can't wait to see everyone in person.
Yeah, so thank you for allowing us to present here. It's quite the milestone, I think, for us, and to be able to share with you today ourselves. And thank you.
There you go. Now you can see this is our command center.
Yeah.
So do you want to open it up for questions?
Yeah, any
now?
questions? Dry informative. I think it's very informative.
Jen McAndrew here. We've also been able to download the chat, so I'll send that to you. So in case there's any questions that I know it's hard to see everything while you're doing the presentation. So we'll make sure you get that in case there's any questions that people were specifically asking. So they will get those. And the resources are on Whova, like you said, they're in the documents section as well, because there's quite a few of them. So, and if there's any issues, we can send them out as well.
Great.
Yeah, I've been scanning the comments while Linda's been presenting. I love all your comments. Thank you for that. I just feel I'm glad that we're all together and helping people.
Yeah.
So
If there's no questions right off the top of the head, we can wrap the session and let people get on. And I know it's a packed agenda. We wanted to try to get in everything as much as possible. So we appreciate this and you coming out. So that's fantastic.
Enjoy the rest of your conference. I'll be on there too. So thank you very much.
Thank you.
Thank you.
Okay, bye, everyone.